So I'm going to talk a little bit about thinking. It's my favorite thing to do, besides sleeping. It's fun to think, and it's not good if you think in racing thoughts, because that's kind of manic and distressing and causes anxiety. And just the opposite happens in Parkinson's disease, where thinking is slowed down, just like all movements slow down. The movement of ideas, which is thinking, slows down too. But that's not the same thing as dementia. A person with Parkinson's disease may be slower to respond to your questions, slower to articulate their ideas, but they're not demented. So the bradykrinia, that's the term for slow processing of thoughts, that's very common in Parkinson's disease, and that is improved with dopamine replacement. The speed of movement improves and your speed of thinking gets more normal. So that's not what I mean by cognitive decline. It's associated with Parkinson's disease. There's a little screening test for cognitive decline that I typically don't go into details to do because we do it just in the initial interview. It's very clear. For example, the questions, it's called the Folstein Mini Mental State Exam. And one makes note of whether a person is alert, drowsy, stuporous, or stuporous. And when asking these questions, if one is very drowsy, you have to take with a grain of salt what the responses to these questions are. So the first set of questions has to do with orientation. That means, what date is it? What day? What month? What year? Where are we? Orientation, space and time, basically. Where are we? They'll say, I'm in church. Then, they're demented because they're in the clinic. And then you say, where are we? They say, well, what state are we in? What country are we in? What is the town that we're in? What floor are we on? So orientation, so right away you get, if you miss all of those questions, you lose 10 points. You're very close to being demented if you're not oriented in space and time. So that's orientation, space and time. This maximum normal score is 30. So someone who is completely disoriented in space and time has a score of 20. And anything below 22 is considered dementia. Most people aren't completely disoriented in space and time. If they are, it's because they're intoxicated, or it's a drug-induced state, or there's an altered state of consciousness. But most people, even demented people, can tell you, want to get a couple of points on this. Like they'll know, yeah, I'm in Sarasota, and I know it's year 2017. Okay, so they get 2 points. The other thing is paying attention. So the way we do that, we have them, you want to see how they register information. So after we see if they're oriented, we ask, just name 3 things, and I show them the things to name. The watch, I said, what is that? What is this? What is this? They name it. Then I say, I ask the patient to state all 3, and they get a point for each one they state. And then I ask them to do mental calculation. This is really hard for most people, even unless you've really always been good at math. And you say, take 7 from 100. That would be 93. Take 7 from 93, that's 86. Take 7 from that, 79. So you see how far they can go. When you're demented, you can't do mental arithmetic. You don't have the working memory to do those mental calculations. And so there, after 5 answers, you stop and they get a full 5 points. They get a point for each one that they get correct. They don't get any of those serial subtraction of 7, they lose 5 points. So if you're, and then the recall, those 3 things that they named earlier, you ask them to name those 3 things. That's a measure of short-term memory. And if they can do it, they get 3 points. If they can't, if they recall one of the 3, they get 1 point. And then there's the language issues. So I show them a pencil, I show them a watch, they name it. That's just word finding. Then I have them repeat to see if their speech is clear. No ifs, ands, or buts to see if there's slurred speech. And then I give them 3-stage commands. Take a paper in your hand, fold it in half, and place it on the floor. And they get a point for each of the steps they can carry out. And then read and obey the following, and I'll write, close your eyes on a piece of paper, and then copy a design shown below. So this is a very simple screening tool. It doesn't tell you what kind of dementia there is, but if you score 22 or less, then one needs a formal neuropsychological evaluation by a psychologist. It can take hours, because then they can see what specific domains of intellect are compromised. So I'm going to now talk into, number one is, what is the epidemiology of dementia amongst the Parkinson population? Epidemiology meaning, what's the frequency of dementia in Parkinson's patients? Who tends to get it? What are the demographics? And then I'll talk a bit about the pathology of the different kinds of dementia we see in Parkinson's disease and how we can treat it. Most importantly, how to distinguish cognitive decline in Parkinson's disease from cognitive decline in vascular diseases like cerebrovascular illness can cause dementia. Alzheimer's disease, of course, causes dementia. And then many of the Parkinson plus syndromes have more dementia than others. And the dementia that's uniquely associated with Parkinson's disease is called dementia with Lewy bodies. And it has very specific characteristics, and the pathology is very clear. And it's where the dementia is the far outweighs any movement disorder. And the dementia can be pretty striking, could be the first thing that the family notices, and can involve all domains of thinking. And very characteristically presents with visual hallucinations. And these are individuals who had been diagnosed with Parkinson's disease and given anti-Parkinson drugs and then have hallucinations. Now, these are people who, even before treatment, are starting to see things that aren't there, having delusions, etc. That's called dementia with Lewy bodies. And what it represents is, and I'll get into that a bit later, is the widespread distribution of the pathological Lewy body. The Lewy body is an intracellular inclusion that accumulates initially in the brainstem, but if it spreads to the cerebral cortices, the latest part of the brain to develop in terms of the course of evolution, it's that big gray cerebral cortex that covers our brainstem and cerebellum. And when the Lewy bodies involve the cerebral cortex, then that's dementia with Lewy bodies. And if you realize what the cerebral cortex has incredibly complex networks and associations. So you see where everything is connected to everything else in terms of your thinking. If those networks for memory are compromised, you have a lot of difficulties. And there's, I'll get back into dementia with Lewy bodies because treating it is difficult. In fact, all of the dementias, regardless if it's Alzheimer's or associated with Parkinson's disease or with dementia with Lewy bodies, it's really difficult to treat the cognitive disorder. There are ways to slow it down, and we'll talk about that, and maybe make it better in terms of short-term memory. So let's talk about the epidemiology. So what's the prevalence, meaning the frequency of dementia in the general population? Not Parkinson's disease, but just the general population. Let's say in Lakewood Ranch or in the city of Sarasota. In general, it depends on what city you're looking at. It may be a little higher if you have an older population, like Sarasota, I think, tends to have a somewhat older population because a lot of people who are retired move here. But generally, community-based studies have found that regardless of diagnosis, about 30 to 40% of individuals have some level of dementia. It's amazing to me. I've always, based on the election results, I think it's greater than that. I'm sorry I couldn't skip that. This is what makes talk show hosts very popular when they bring in. But it's 30-40% of the community, of some community-based surveys found that they are dementia. It doesn't say what kind of dementia and how bad. It could be just beyond normal age-associated memory decline. But what about a population of Parkinson's disease? Is it higher than that? It is. If you look at dementia in a population of Parkinson's disease, it varies from 10% to 80%. Depends on, now, when I talk about a population of Parkinson's disease, it includes the people just newly diagnosed and those that have had it for 30 years. So it can range from 10% to 80%. So then people want to know, what is the natural evolution of dementia in someone newly diagnosed with Parkinson's disease? There have been a number of studies about that. There's a really well-known study. I have to here. Even in young onset patients, that means 21 to 40 years of age when the diagnosis of Parkinson's disease was made. And one of the studies showed 19% of them had evidence of dementia. So 1 out of every 5 young onset PD patients at the diagnosis have some indication that they're having cognitive difficulties. And remember, dementia just means it's cognitive difficulties sufficient to interfere with your ability to function independently. There was this great study done over 5 years in Sydney, Australia. It involved multiple centers. And the neurologists in Australia were asked to refer their newly diagnosed patients with PD for a 5-year trial comparing low-dose carbidopa with bromocriptine. And they did a series of neuropsychological assessments performed at baseline 3, 5, 10, and 20 years. And at the very baseline, at the beginning of the study, they found that, what percentage? This is too important to find that percentage, but it was about 30% of the patients were demented. And then by the end of the study, they found 83% of the patients had developed. This was after how many years? 20 years. So over a 20-year period, they start with the number of patients with dementia in essence doubles, and it's pretty high. In an earlier study, they found that dementia in PD was about 40%, just like the other study. And even though they exclude patients with dementia with Lewy bodies, and then they eventually end up about 75% of those newly diagnosed patients after 15, 20 years will have dementia. So what are some of the clinical features of dementia in Parkinson's disease? As I said, it's really different than the Alzheimer's dementia. With the Alzheimer's, and I'm going to get back to this when I talk about the neuropathology, what parts of the brain are involved, involves more memory, both short-term, mostly short-term, and just imprinting of events that happen in the day. Person would see a child, maybe have such and such a thing for breakfast, and do a number of things. If you ask them what they did, they can't recall what they ate, what they did just a few hours ago. And that's an example of severe short-term memory problems. It's very typical of the Alzheimer's dementia. That kind of thing is very, very rare in Parkinson's disease dementia, the memory issues. Parkinson's disease patients have the same cognitive problems as just normal aging. In other words, some problem with short-term memory, word finding difficulties and that kind of thing. A little bit of word finding difficulties. The other thing that happens in the most important distinguishing feature between the dementia of Alzheimer's and that of Parkinson's disease, that early on, what Parkinson patients have are problems that we'll say frontal lobe-ish problems, which have to do with executive function. Now, the frontal lobe doesn't exist by itself. It's heavily interconnected with posterior parts of the brain and deep gray structures of the brain, the emotional brain, the deep gray structures mediating movement. So when the frontal lobes are compromised, or connections between the subcortical to the frontal cortex, when those connections are interfered with by the disease process, people have problems with foresight, planning ahead, following through, multitasking. So being able to do multiple step commands becomes very difficult. It's like one of the things you pick up when you say, you give a command to test that. Take this piece of paper, fold it in half, and put it on the ground. So they'll take the paper, And if they're really bad with executive function, they forget what they have to do next. They forget to fold it, or they'll fold it and then don't know they have to set it down on the floor. So that would be just a very crude assessment of failure to be able to follow through on a sequence of commands. Oftentimes just doing 3 things at once. So if I ask a patient, close your eyes, extend your arms, and count backwards out loud. So they'll close their eyes, extend their arms, and you have to remind them, now count backwards. So they're quiet. I say count backwards out loud. So that's an example of someone has problems with executive function. A classic example of executive function problems is being able to switch from one set of rules to another. And that's why it's called an executive. Think of an executive on the phone. It doesn't have to be Donald J. Trump. He's given a whole bunch of information, and then another line rings. He says, hold on. And then he's given a whole bunch of more information, completely different problem. Okay, thank you. You get back to the other, and you should, if you have good frontal lobes, you could immediately go back into the original call. But if you have problems with executive function, you get hung up. You can't recall what you were talking about, who even you were on the phone with before the second call interrupted you. So that's an example of, and that's very typical deficit that people with Parkinson's disease have. Which brings me to an anecdote. When I was at the University of Miami training in Parkinson's disease with Bill Weiner, Janet Reno was diagnosed with Parkinson's disease by Bill Weiner. You know, she was Attorney General, but she was based in Miami. She was a prosecutor in Miami for many years. And she had mild Parkinson's disease, tremor predominant. And the question was raised of Bill Weiner, you think, she's an executive, Attorney General, that's an executive position. You have to be able to multitask, switch, carry out plans, plan ahead. You have to plan ahead. And that's hard to do if you have a executive dysfunction. So Bill Weiner said, well, at the moment she seems to be okay, but with time, she'll probably not be able to serve as Attorney General. Now, that was a very delicate thing to have to say. And the reason he said why she can continue to work as Attorney General, she had mild Parkinsonism, it was tremor predominant. And it turns out, and I'm jumping the gun here, that there's certain clinical phenotypes, patterns of Parkinson's disease motorically, that can predict whether you're going to develop a dementia or not. So we know that individuals who have tremor predominant Parkinson's disease, where the slowness and rigidity isn't the big thing, it's just the tremors. And the tremors, of course, drive them crazy, and sometimes they don't disappear with levodopa, carbidopa treatment. But the good news about tremor predominant Parkinson's disease, they tend to have the least likelihood of developing dementia. It's the rigid akinetic form of Parkinson's disease where they have no tremor that is much more likely to develop dementia. Even though they feel pretty good, no one can tell I have Parkinson's disease and I have no tremor. Hey, I never had tremor, doc. But the rigidity and the slowness is correlated with likelihood of dementia, predicts dementia. Okay, so in time, as Parkinson's disease gets more advanced, and this is a time-dependent thing, age-dependent thing, other cognitive issues come into play. And they start looking more like Alzheimer's type things. So they then do begin to have memory problems or problems with abstract thinking. And not just the planning ahead, but memory and abstract thinking and mental arithmetic become more compromised. So it looks like they're starting to get Alzheimer's-like, but they never get quite as severe as the Alzheimer's patients when it comes to memory problems. The other thing that happens in Parkinson's disease is that if they didn't have hallucinations at the beginning because they don't have dementia with Lewy bodies, with time, people with Parkinson's disease, 1 out of every 4 patients with Parkinson's will, with time, develop hallucinations. And that's associated with cognitive decline and worsening of visual spatial organization in the parietal lobes and occipital lobes. And it turns out that that's also an early abnormality we see in Parkinson patients, that we tend not to think of it as a part of dementia. But one of the last things we ask people to do is make a copy of a drawing visual apraxia, difficulty in seeing things in space. One's personal space is compromised. You kind of don't know where your body is in space. Worse, where your car is in space. So this visual spatial decline happens very early in Parkinson's disease. It accounts for why when people are driving, they're fine with their Parkinsonism, they have a little bit of slowness and rigidity, but because of the changes in their occipital parietal lobes, when they make a right-hand turn, tend to clip the curb with their right wheel or hit a few mailboxes on their country road. And when they park, they're not in their parking space, they're in the neighbor's parking space part of the way and crooked. So, and it isn't that it's a woman who's driving, it's a Parkinson's disease patient. I take it back, my wife's an incredible driver. I let her drive. So this is, and as the illness advances, this visual changes can result in hallucinations, but typically those hallucinations in more advanced Parkinson's disease occur when there's a really serious sleep disorder, which is one of the other non-motor manifestations of Parkinson's disease. It's fragmented sleep, problems with dream sleep, and so you start dreaming while you're awake, and those are the visual hallucinations. And they're worsened by dopaminergic drugs. So I'll tell you how we treat that. So we can have in dementia with Lewy bodies, which is presents with marked dementia involving all domains, it presents with visual hallucinations even without medication. And then when you examine them, you start seeing Parkinsonism, slowness and rigidity. In the case of the hallucinations you see in Parkinson's disease dementia that occur later after 5, 10, 15 years and is dependent in part on the drugs you use, and dependent on how well you sleep, and dependent on how much dementia there is, because if one is already markedly demented and then takes these drugs, one is more anti-Parkinson drug is likely to have visual hallucinations. And if it was just visual hallucinations, it wouldn't be so bad, because some of them are fun, according to some of my patients. No, I mean, this one patient would say he loved his hallucinations. Please don't get rid of them, because every evening as the sun is going down, I sit on my porch, which faces a golf course, and as the sun's going down, the twilight, there's this horse, beautiful horse, and as it comes closer, I see there's a woman riding it. And to my surprise, she's not wearing clothes. Naked, bareback horse riding every evening. Don't get rid of that. Right. So, but most of the time, hallucinations are unpleasant, and it's associated with other things. So, delusions of jealousy, like convinced that your partner is having an affair with a neighbor, even unlikely as it may seem, or that someone is poisoning you, trying to poison you, or strangers are trying to break into your house to steal your things. Those are scary, and that's associated with advancing Parkinson's disease, hallucinations, and delusions and psychosis. In essence, it's a psychosis. So if you have a dementia, you're more likely then to develop a psychosis in advanced disease. Now there are things that we do for this that we'll get into. I'm going to turn the page to neuropathology, and that's what we know about what's happening to the brain in these different conditions. The dementia of Alzheimer's disease versus dementia associated with Parkinson's disease. And it's simple as this. It's the population of brain cells that are predominantly affected determines the dementia. In the case of Alzheimer's disease, there are neurons that make acetylcholine, and they're in the frontal inferior forebrain. They start degenerating, and they're a very critical component of memory networks. And so those symptoms develop when the subcortical, the subfrontal, called cholinergic neurons of the nucleus of Maynard, that's the name for this population. Just like we call the neurons that cause Parkinson's, these dopaminergic neurons of the substantia nigra. In Alzheimer's, we have cholinergic neurons of the nucleus of Maynard. When those die prematurely, one develops symptoms of Alzheimer's disease. So one is a dopaminergic deficiency predominantly, the other is a cholinergic deficiency. So the treatment for Alzheimer's disease is to increase acetylcholine levels. That's what Aricept is for. And other drugs that we use for dementia tend to increase acetylcholine activity. It doesn't really help memory that much. It helps a bit, so people are automatically put on that kind of drug. In the other aspect, besides what neurons are lost, what is the pathological marker? What is the agent that accumulates in these cells that causes them to dysfunction and die? In the case of Parkinson's disease, you all know it's Lewy bodies. And when they spread everywhere, you have dementia with Lewy bodies. In the case of Alzheimer's, it's called amyloid plaques and neurofibrillary tangles. Two kinds of abnormal proteins accumulate. The amyloid plaques accumulate between brain cells, and the neurofibrillary tangles are neurofilaments that are twisted within neuronal fibers. So they have two kinds of pathological markers in Alzheimer's disease. So one is Lewy bodies, and they distribute in the brainstem, and if they get everywhere, you have dementia. In the case of Alzheimer's disease, those plaques can spread everywhere, and the neurofibrillary tangles can spread everywhere, so it causes a global dementing illness. So how about treatment? Well, to improve cognition with medication, we do use compounds that increase acetylcholine activity. Now, Aricept is the most common. There's a bunch of others that are similar to that. There is some evidence that it may improve short-term memory. Now there's a more recent drug called Namenda. It's not clear exactly how it works to improve cognition and memory, but we do that also in Alzheimer's patients. Now what about Parkinson's disease dementia? Well, there's an interesting overlap in some patients. Remember I said it starts off with executive function when it's the case of Parkinson's disease and slow thinking. Some of that can improve transiently with dopamine replacement. But when the illness advances and they start having what looks more like Alzheimer's symptoms, more short-term memory problems, mental arithmetic problems, abstract thinking problems, orientation problems, getting lost in your own home, that can all happen, and it looks just like Alzheimer's. So there's like an overlap between in Parkinson's disease brains, patients, where there's some Alzheimer's-like behaviors and some Parkinson-like behaviors. And it turns out that a certain fraction of people with dementia and Parkinson's disease is that they have both conditions. And the reason we know that, some of these cases, when you examine the brain, you'll find the pathological markers of each of those conditions. You'll find Lewy bodies, indicating that it's a Parkinson dementia, and you'll also find amyloid plaques and neurofibrillary tangles. I already told you, and I've told it many times, the most common neurodegenerative disorder in the United States is Alzheimer's disease. And the next most common is Parkinson's disease. And it's not unusual to have people with both. So the only way we used to be able to tell is by looking at the postmortem brain. Now in the case of Parkinson's disease, we don't have an in vivo marker of Lewy bodies. We can tell if there's dopamine deficiency in vivo in living people with DAT scan and PET scans, but you can't just look at the distribution of Lewy bodies in living people. In contrast, in Alzheimer's disease, you can visualize and estimate the amount of amyloid plaque in the brain. In other words, you can confirm a diagnosis of Alzheimer's disease, not just by the neuropsych profile, it gives you a strong indication, but the PET scanning for amyloid plaque allows you to confirm and look at the distribution of the amyloid. So if you have a patient with Parkinson's disease and dementia, but you want to see how much of it is real Parkinson's dementia versus Alzheimer's dementia, you do a PET scan. And if you happen to see amyloid plaques, then you know that this patient has both Alzheimer's disease and Parkinson's disease. So that's where there's some overlap. In the case of the dementia with Lewy bodies, the pathology is not neurofibrillary tangles or amyloid plaque, it's just Lewy bodies distributed throughout the brain. So I'll start with how we treat that, because it has application to how we treat, the effects of the consequences of dementia and Parkinson's disease, which is often psychosis and hallucination. So in the case of dementia with Lewy bodies, which is the worst extreme, of Lewy body disease, because Parkinson's disease is considered a Lewy body disorder. And dementia with Lewy bodies is where the Lewy bodies have spread everywhere, and where the clinical manifestations are more dementia than movement. So the treatment for dementia with Lewy bodies, since is geared towards stopping the hallucinations and psychosis. It isn't geared towards improving their motor function, because usually they don't have much involved in terms of the Parkinsonism, at least in the early stages. And if you were to give them dopamine replacement, their hallucinations would get much worse, they'd become more psychotic. So you can't just, and someone with dementia with Lewy bodies, who happens to be slow and rigid, you really should not start off with dopamine replacement. You're going to exacerbate their cognitive deficits, worsen the hallucinations, and create a frightening situation. So we use medications that can be given to Parkinson's disease patients that don't worsen Parkinsonism, but do stop hallucinations and psychosis. So all of you have heard me talk about how we discovered dopamine in the late 50s and 60s, was because there are major tranquilizers, antipsychotic drugs, Thorazine was the first, that block hallucinations, psychosis, aggressive behaviors. They block dopamine receptors in the emotional brain, but they also, as a side effect, block dopamine receptors in the movement part of the brain, the nigrostriatal system. So a consequence of using antipsychotic drugs, of the classical drugs, is to produce Parkinsonism. So if someone's hallucinating, you give them a drug to stop hallucinations, but it worsens the Parkinsonism, you can't do that. Right? So what do? Well, there's a new generation of tranquilizers, the antipsychotic drugs, that don't block the nigrostriatal dopamine system. In other words, they won't produce Parkinsonism. The first to come into play was Clozaril, which is a fantastic drug that we use when people with Parkinson's disease started developing visual hallucinations. And if you took away their anti-Parkinson's drugs, they'd get a little better, but then they could hardly move. But if you gave them Clozaril, their hallucinations would go away, their mind would become clear. I mean, they still may have some dementia, but they were at least based on reality. You know, what was happening was real. And they could then take anti-Parkinson drugs because they were protected against hallucination, psychosis by this Clozaril. The unfortunate thing about Clozaril, which is available about 20-some years ago, it's still available, and I'll use it on rare patients, but it's a patient that doesn't mind having a blood draw every week and then every month and eventually every few months for the rest of the time they take the drug, because Clozaril has an unfortunate side effect. It's rare as can be, but it could be fatal, where it suppresses production of the bone marrow cells. So you become anemic and susceptible to infection. So anyone who takes Clozaril, none of my patients take it except one left, and I'll tell you why. She kept taking it in a moment. But this drug is a fantastic drug, but it's too risky to give, and it's a hassle, and you have to really, the patient has to be willing to take the risk and be willing to have someone draw blood every month. Because the white blood cell count is sent to me, and if it's okay, then they can continue getting renewals of the prescription. A variation of Clozaril that came into play is called quetiapine or Seroquel, and that one is remarkably safe, does not cause worsening of Parkinsonism. It doesn't block the dopamine receptors that mediate movement. So you can treat the psychosis, the hallucinations, and delusions with Seroquel, and the doses we use for that tend to be higher than doses I tend to use just to improve sleep, because a really low dose of Seroquel at bedtime is really great for people who have fragmented sleep, who don't have deep sleep. But a somewhat higher dose, and taken at low doses during the day, you can completely stop visual hallucinations, delusions, and psychosis. More recently, there's a Nuplazid. Nuplazid is a new atypical tranquilizer that blocks hallucinations. I have no experience with it, but it's starting to become available. So that's what we do first with dementia with Lewy bodies. Once they're not hallucination and aren't confused or psychotic, one then can consider using levodopa, carbidopa to treat their Parkinsonism, which is usually not the biggest issue. It's mostly the cognitive issues. The other thing I do with dementia with Lewy bodies is I'll try Namenda or even Aricept, one of those two drugs both of which are used for Alzheimer's, decline. It sometimes helps. In the case of Parkinson's disease with dementia, who then develop hallucinations, there are several steps. One is to slightly lower the anti-Parkinson drug to see if those hallucinations disappear. If you can lower the drug and the hallucinations disappear, but there's not much worsening of the Parkinsonism, in other words, they can still move well, then that's great. You don't need to use Seroquel. But if you lower the anti-Parkinson drugs and then you make their Parkinsonism intolerable, then you can start using Seroquel with them. And once the hallucinations are gone and they're not fearful or psychotic, then you can reintroduce the anti-Parkinson drugs. And again, with these patients, I will give a trial of Namenda or Aricept to see if that helps. Final bit of advice I give to all patients, including people just newly diagnosed or people who have more advanced illness, is the importance of cardio aerobic exercise as a way to improve cognition and delay progression of both Parkinson's disease, Alzheimer's disease, and dementia with Lewy bodies. It really works for all three. And it's not like something you notice right away. You have to keep at it for years to really reap the benefits. And by cardio aerobic exercise, I mean exercise that you do at least 3 times a week, a minimum of 30 minutes each time, that results in your heart rate going up to 80% of your maximum heart rate for your age. And if you do that on a stationary bicycle or by brisk walking in which you monitor your heart rate, or on a treadmill, or some kind of other step exercise, aerobic exercise, that really does a number of things on your brain. It increases the production of fertilizer for brain cells, known as neurotrophic factors. They stimulate the rebirth of new neurons in the part of the brain where we make neurons throughout life, the hippocampus. So in that way it improves memory, and we've demonstrated that in animal models of Alzheimer's disease, where we had them exercise on a treadmill, and they had to do this and increase production of the BDNF and GDF2 growth factors that stimulate production of cells in the hippocampus, which is a key node for short-term memory. The same thing happens in individuals that are made Parkinsonian, or monkeys. They have unilateral Parkinson's disease induced by injection of a toxicant. And forced exercise there results in increased neurogenesis, increased sprouting of remaining dopamine neurons. And to the point that they reinnervate the striatum and their motor function improves. So the cardio aerobic exercise not only enhances cognition, it enhances motor function. So absolutely essential that everyone take up a cardio aerobic exercise. If you have to have a cardiac history, you've had an MI or had stents or coronary vessel disease, talk to your cardiologist about the limits of your exercise program. A lot of these cardio aerobic exercises were designed to help cardiac patients, but they can be applied to Alzheimer's and Parkinson's disease as well. So I'm going to end it here, and I'll be glad to take a few questions.
Did I hear you say that dopamine replacements that is not good for dementia?
No, I didn't say that.
No, you didn't.
He said, did I hear you say dopamine replacement is not good for dementia? No, I said, actually dopamine replacement is good for bradykhrenia, the slowness of thinking, and can improve some executive function. In other words, that part of dementia that you see predominantly in Parkinson's disease early on, sometimes it's better with dopamine replacement. However, when the illness, dementia is more pronounced, and there's more cognitive decline, and starting to look more like Alzheimer's, and then you're starting to hallucinate. Well, the dopamine stimulation will worsen that, will cause worse hallucinations and psychosis. So that's what I said. So,
What about the Exelon and Dementia together? Is there any advantage to that?
they work through different mechanism, and yes, Exelon is a lot like Aricept. It increases acetylcholine. The Namenda actually potentiates a bit of dopamine, but it has other effects on systems that are not clear how It's not clear how it really does improve cognition, but there's evidence that it does. So yeah, using them both is very common. Yeah.
Oh, someone with advanced Parkinson's, is it worth it to get a PET scan? Or what would that show?
Well, someone with advanced Parkinson's disease, is it worth it to get a PET scan? What I needed to know is the person demented? Does the dementia fit the Alzheimer's pattern, or does it fit more a Parkinson pattern? For that, PET scans are expensive, insurance won't cover it, so I would do neuropsych testing. Do a neuropsych screen to see what the nature of the dementia is.
Well, we didn't even get to a half an hour. Neuropsych. No.
Well, if you want to know what the likelihood of him having Alzheimer's as well as Parkinson's disease, then you do a PET scan, and you can do it at the Bird. They do them, and some insurance companies will pay a portion of it, but a lot of them they think of it as experimental.
What would it show?
Well, knowledge is empowering. So now I know. Well, he's got some Alzheimer's. Maybe we have to do some of the new things that are happening for Alzheimer's, like the vaccine for Alzheimer's. On the other hand, if he has no amyloid plaques, then you don't have to think about treating the Alzheimer's, just focus. That's the only thing. But in general, without knowing whether it's Alzheimer's or PD or both, you can still do the Aricept or Exelon and the Menda and see. Yeah, so that's about all you can really do. But right now, the vaccination things are completely experimental.
Oh, yeah.
But if you ever want to be a candidate for a study in which they'll do a vaccination, they'd probably want to confirm it's Alzheimer's, and they do the PET scan to see whether it's Alzheimer's disease. There's another way they can do it is by an LP, and they measure fragments of the beta amyloid in the spinal fluid, and that helps diagnose it. But the PET scan is probably the more useful.
Is the drug rivastigmine?
Rivastigmine.
Rivastigmine.
It's in the same class. They're all anti-cholinergic drugs. What they do is increase the production of acetylcholine in the forebrain. Rivastigmine, which is Exelon, Aricept,
Okay, now are there
Donepezil is
studies that
Aricept.
show because the doctor has increased him up to 18 milligrams a day and wants to increase him to 24 milligrams a day? Are there any studies that show, I have no baseline.
What happens with too high a dose? It creates loosening of the stools and some autonomic nervous system function. But you should go empirically and see if it helps. And because the side effects are not so horrible. There's a funny thing about anticholinergic drugs. They were the first drugs to be used in neurological disorders before we used them in dementia. They were used for myasthenia gravis. Because in myasthenia gravis, which is a neuromuscular junction disorder, the famous guy was Onassis, who died of myasthenia gravis. It's a pretty common illness. You become weak in focal muscles because the nerve endings make acetylcholine that are released to stimulate muscle. So when you lose the capacity to release acetylcholine, because you're losing those cholinergic, there's a problem with antibodies against acetylcholine receptors on the muscle. One becomes very weak, and if the diaphragm is involved, you have problems with breathing. So the drug that is used to treat myasthenia is a cholinesterase inhibitor, very similar in action to what we use to treat Alzheimer's disease, but it acts peripherally, and it increases levels of acetylcholine in the neuromuscular junction and improves motor activity. So the other drugs act centrally to increase acetylcholine activity. If you want overall acetylcholine activity to be increased, that's a nerve gas. Sarin is a cholinesterase inhibitor, like some of the pesticides. If you poison all the acetylcholine enzyme, acetylcholinesterase, which is responsible for ending the action of acetylcholine, that's why if you inhibit it, you get more acetylcholine activity. In those conditions in which there's not enough acetylcholine activity, Alzheimer's, myasthenia gravis, you give an anti-cholinesterase drug that blocks the breakdown of acetylcholine, and that's therapeutic. But if you give a drug that potently binds to acetylcholinesterase, the enzyme that's in all the nerve muscle junctions, people die. Or if it gets into the brain, it causes seizures, and that's what sarin does. Sarin is a very potent nerve gas, and what it does is Same kind of action as a therapeutic drug. This is an example of typical for Parkinson, for pharmacology. It's a low dose may be a medicine, high dose can be toxic. Same kind of drug. What we kill our roaches with are also cholinesterase inhibitors. So think of it, we're using cholinesterase inhibitors as therapeutic agents to improve thinking, but very specific, highly potent cholinesterase inhibitors are nerve gases that are banned, but still occasionally are used illicitly. And pesticides. Some pesticides will use cholinesterase inhibitors. So I think I'm going to end it there. I have to prepare for the clinic. Don't be afraid of taking anti-cholinesterase drugs for dementia, because they're different drugs, they're therapeutic, they act on brain, they don't. If you take really high doses, what it'll do is get rid of your constipation. Because it loosens the valve.